How does mother-to-child transmission of HIV occur? How does HIV treatment prevent mother-to-child transmission of HIV? And how can a woman living with HIV benefit from antenatal care? Hello and welcome. I'm your host, Dr. Musamtomeli. Signing with us today is Trifosa Ntwelengwe. Our Vital Signs will focus on pregnancy, breastfeeding, and HIV. Coming up on the program, we'll listen to a report compiled by reporter Sellwane Khakhau and video journalist Zandile Kubeka about the challenges faced by pregnant women in rural areas in the Northwest Province. We'll then speak to facility manager at Discovery's Community Health Center in Gauteng Province about other things, and of course we'll speak to the assistant director in the Directorate of Child, Youth and School Health at the National Department of Health about preventing HIV during pregnancy, delivery and breastfeeding. Remember that you can be part of the show by asking the guests that we'll have on any question that you may have on your mind. Simply share your view with us on what we're discussing. The number to call is 011-714-0677 or 011-714-0678. You can also share your thoughts with us on social media, on Twitter at SABC Vital Signs or Facebook SABC Vital Signs. The show will continue after this ad break. Stay with us. Welcome back to Vital Signs. Now, some pregnant women in rural areas and informal settlements in the Northwest are faced by a range of challenges that prevent them from consistently attending antenatal care clinics. Now, these challenges include socioeconomic factors, lack of access to information, as well as an alleged ill treatment at healthcare facilities. Now, some of these women do not know how to protect their unborn babies from contracting HIV. This, despite South Africa's prevention of mother-to-child transmission program being listed as a global leader in 2020. Now, according to The Conversation Africa, an independent news source, more than 95% of women are being tested for HIV during antenatal care, and more than 90% of HIV-positive women are being initiated on antiretroviral treatment. Now, The Conversation Africa states that HIV infection rate at birth is currently around 1%. Reporter Sellwane Khakhau and video journalist Zandile Kubeka compiled this report.
Well, we're coming to you from Gauteng informal settlement just outside Mahikeng. It's actually situated in between Ottoshoop and Mahikeng on your way to Zeerust here in the Northwest. And this informal settlement does not have any basic services. And we know that the residents struggle a lot also in terms of accessing healthcare facilities. There is no clinic here. The nearest clinic to this informal settlement lies about 17 kilometers away from where we are. And it's quite a struggle for the residents to get to the facility because there is no public transport. They have to depend on hiking. And you can imagine for somebody who is not well or somebody who is ill or a woman that is pregnant, it is not practical for them to walk such a distance to and from. And so today we are exploring the topic of pregnancy and how much do women here understand about pregnancy? Are they able to access information when they go to the nearest clinics? Or what are some of the challenges that they face? And the panel that I have here next to me is a professional nurse, Betty Mosala AC. Now, I also have some of the women joining me. Some of them are expectant mothers. They are pregnant. And I also have a mother of a 13-year-old child that is also expecting. She's pregnant, and so, of course, she's underage. She's not going to be joining us. But let's get straight into the topic first. We're going to have this conversation in Setswana. Ke leboha bagolo le re joinile ke kopa le re hlalosetseng pele re tlo bua le lona hore nang lona information ka ha o le pregnant ya le fihlella ha le ya go di clinicing tse haufi le lona o se dina o ke kopa go ke qale ka wena
ya re tsama clinic ko Tozio ko Marupin clinic mare nna ga ke khotsofalle ba re tlhalosetsa e ya mare ga re felletse re ha khotsofatse go tlohle nna ke feleditse ke change clinic ke ya starting clinic.
So we also want to understand how much you guys understand about what you're supposed to do when you find out that you are pregnant, or maybe find out that you are HIV positive while pregnant. We want to understand if you understand or how much you understand in terms of what you're supposed to do to protect the baby, to make sure that he or she is not born with HIV.
Ga ise ba re tlhalosetse ka information ya gore ga o imile o bo o fitlhela le gore o HIV positive gore o tshwanetse o protect ngwana ga go yang.
Ha ba re ga sepe gore re ka fitlhela re na le HIV gore re sireletse ngwana ka eng.
According to the nurse, it is not surprising that women in rural areas do not access such crucial information.
We find out sometimes that the information have agree, they don't get the information, but it is important that on the first bookings of antenatal care, that each and every patient needs to get a thorough treatment based on health education of antenatal care, and we do blood investigation also, and also monitoring the child, and also treatment needs to be given to them.
And it seems that lack of information is not the only challenge for these women, but they are also faced with socio-economic issues. This mother says she cannot afford transport to take her 13-year-old pregnant daughter to an antenatal clinic as regularly as expected.
Clinic nga tlodisa go clinic re tlhola le gore a rena tšhelete ga rena madi a go clinic.
They say another big problem that makes it difficult for them to go to the clinic is the alleged ill treatment they receive from healthcare professionals.
Ne ke kopa dinese di re tshware sentle ka gore ha re tsena ko tleliniki ha re tlodisitse ba re kgadi e petsa ha re ba bolella mathata a rona gore ha rena madi a go palama ba re le gore borra go bana ba rona ba kae a ile gore a ne re ithobala la re sa tlhaloganye sentle go tle bogote ra apole re kana mo godimo ga betha ke botsa gore a ke apole gotlhe re tle ba sa gagebe sentle.
Ngwana ga tsena go tleliniking ko bophelong ga ba mo tshware sentle ba mmitsa under age ba mo go itlhelele gore yanong o maikutlo a gagwe ile ko godimo wa lla tsena go tleliniki.
Healthcare professionals say such treatment should be reported.
It is important that immediately if you are not happy with the service that has been rendered to you, you need to complain to the facility manager or sister in charge on the specific day, or there's a suggestion box where you can write your complaint and put it in the box.
This is where the residents of Gauteng come to catch a hike to the nearest clinic. But this long road that you see behind me is not even half of the distance to the clinic. And it is not always guaranteed that cars will stop by to offer them a lift, especially if they don't have money to pay. If they are not lucky, they will either have to go back home or walk the distance. Now that is how many of these pregnant women miss their appointments at the clinic. Sellwane Khakhau, SABC News, Mahikeng.
After the break, we continue this discussion with Matron Prudence Mapeka, as well as, of course, more conversations that will happen. We'll see you after this. Welcome back to Vital Signs. Now, can an HIV positive person transmit HIV to their baby anytime during pregnancy, childbirth, or breastfeeding? Can you have a healthy pregnancy with HIV? And of course, how can you protect your unborn baby from HIV? With so many myths around HIV pregnancy as well as breastfeeding, with many women, of course, not being sure what this actually means because of stigma as well as a lack of information, we're not able to make these informed decisions about all of this. And of course, after a diagnosis of HIV has been made, especially during pregnancy. Now, while government facilities offer antenatal care and support in languages that most women can understand, many women do not attend antenatal care. Now, to help us answer these questions, we welcome Matron Prudence Mapeka, who's the facility manager at Discovery's Community Center. Thank you so much for joining us today. I mean, being the boss at a health center has got a lot of things because you cover casualty, you cover day-to-day illnesses, but importantly, you also have to look after antenatal care. So what does antenatal care actually encompass?
Okay, thank you so much, Dr. Musa, and the viewers out there. Antenatal care is very important in that when a pregnant woman starts becoming pregnant, they need to be observed closely for various tests that are conducted there at the facility level. So I would mention a few that are very important, which is testing for HIV, testing for syphilis, which is also a sexually transmitted infection, as well as hepatitis B. We also test for those ones. The Rh, the rhesus factor, to see the antibodies in the mother before they give birth. We also screen for pap smear depending on the age, because pap smear cannot be done at any given age. But you know, with pregnancy, a woman can be pregnant at any age from the childbearing age. So it is most important to test for such so that we exclude any problems that might cause the pregnancy outcome to be a complication.
Now, there are a number of things, like you've mentioned, that are available and should be done when you are doing antenatal care visits. But why is it important that someone that is pregnant or thinks they may be pregnant goes to ANC or these antenatal clinics to be seen, to be checked, and to continue to follow up?
Okay. The first thing is, once a woman knows that they have missed their period, that is the crucial time for them to attend to our facilities for antenatal care. They start at the family planning to check why they missed their periods, and then they would do pregnancy test on them. Once it is confirmed, then we want them to book early for their antenatal care. Why we are saying that? Because it is very important for a woman to book early so that we can test for all these issues that I have mentioned before, so that we are able to pick up anything that might be a risk for the baby and the mother, especially with the HIV one. HIV is curable. It's not curable per se, but we can prevent it from transmitting from mother to baby. While we are gonna take this mother, test them for HIV, and then we initiate treatment as soon as we see that the mother is HIV positive. Because now, if the mother is positive, the transmission rate is very high because that mother won't be knowing their viral load. Viral load is the level of HIV in the blood, as we all know. So we give treatment immediately so that the viral load can be suppressed and the mother can have a safe delivery, including the breastfeeding of the baby afterwards. So it is very important for mothers to know their HIV status before they attend to antenatal clinic. It goes to the partners as well, because mothers are not just alone in this pregnancy. We've got fathers that are supposed to also attend with the mother in the antenatal care so that we test both the partners. Because mothers, normally they come alone to the clinics, which we discourage most of the time. They need to have the partner on the side so that if both of them are testing for HIV, both of them can be on treatment. Because if it's only the mother that tests for HIV alone, then the reinfection phases go on and on with the partner that is not tested, which is the father-to-be to this unborn child.
Now, you've mentioned something important, which is this risk stratification that you do, that there are people that are low risk, that are people that are high risk as well. What does this actually mean?
Okay. With the pregnancies, the high-risk group, that's why we classify them during the antenatal care. When you start booking early, we can classify whether you are high risk, medium risk, or low risk. with the high-risk pregnancies, pregnancies that comes with hypertension, diabetes, cardiac problems, epilepsy. There are those women who are having those pre-existing conditions. So it helps us in the antenatal side to check for such conditions so that we make proper delivery plan for these women, because they cannot deliver at any community health center facilities where it's only midwifery related facilities.
Yes.
So it's better for us to look at them at that stage when they come to the antenatal side, so that we classify. The medium risk ones are those maybe that comes, maybe they've had pregnancies before whereby they had postpartum hemorrhage, maybe they had a previous Caesar before, but it was just because of a complication. They can attend to a normal antenatal, but at a later stage, we advise for them to deliver at a hospital level. And then we've got those with no risk at all. The low risk ones, maybe the first time pregnancy, depending on the age though. You know, we've got teenagers who become pregnant. We don't deliver them at an MOU setting. We refer them to a hospital setting.
Yes.
Yes, because they might go through Caesar or that. So the low risk ones is those without any complications during their pregnancies, whereby everything is normal, they don't have any problems with their pregnancies. So it's very important for those women to attend, so that we are able as midwives to plan for their delivery purposes. Because if they don't do that, they come to the facility, they complicate, and then it's a problem.
Now, this idea of antenatal visits, an important one, and I guess that's the reason why we're having today's show. And you've highlighted an important thing of booking, that people need to, as soon as they find out that they're pregnant, book for their antenatal clinic visits. How many visits are there? Who should be booking? Does it matter if I've had a child before and I'm pregnant again for the second time? Should I book for the second time? Who actually has to go to ANC clinics or AN clinics?
As soon as a woman is missing her period, that is the time to book, whether you've had the baby before or not.
Okay.
Remember, even if you had a baby before, you might be pregnant before the other one is of the age of becoming an infant. We also try to advise mothers not to be pregnant earlier. There should be child spacing in between their children, so that attention is paid more on the other baby than the other. But everybody that is a childbearing age, once you miss your period, it doesn't matter when, you must come and check in the clinic, and then we book you immediately.
Once you are booked, what then is the procedure? So you've mentioned that you'll do the test for syphilis and HIV, we'll check for hepatitis, you'll look for comorbidities if you have a heart problem, epilepsy and things such as that. From someone, for instance, who's a low risk, this is their first pregnancy, they're 25 years old, you've now booked me, how many more visits will I have? And what am I taking in that time? Do I get medication and all those sorts of things?
Okay. We are happy to have them as early as possible, so that they are also accommodated. The total number of preferred visits will be 8 visits.
Sure, okay.
Yes, for a pregnant woman. But others, they book late, which we discourage mostly. Hence, I'm saying as soon as they notice the first month I've skipped my period, then I need to go and check. Then we catch them very early, before 12 weeks or before 20 weeks. Then we are able to schedule their visits according to the number of the desired visits that they need to come to the clinic. What we do when they come for the visit, first of all, we take their history. You know, we've got different histories that we take at the antenatal care. We check for their medical history, family history, if there's twins in the family, because it can be inherited, you know that. Ne? And then also, we also check for any surgical history that a person might have had before in their reproductive areas.
Okay.
Yes, and then we do physical examination, whereby we check the oral health of the mother, because if once there's a problem with their teeth, we can't do anything until they deliver. So to prevent that, we must check everything from head to toe. We check for enlargement of their lymph nodes around the ears. We check body-wise, the pallor, the skin, so that we exclude anemia. And then we go down, head to toe, We check their chest, the sound of the heart, is it okay? We check the size of the abdomen. We do SFH measurements to determine their gestational age. We check for genitals, any STI infections that might be found there. We go down to the legs, the veins, varicose veins, so that we give the mother the desired treatment that they need. As well as after that, we do HIV testing and counseling for them.
So let's talk around this HIV testing and counseling, right?
Yes.
So we know that once you've come in, you're booked at whatever stage that you find out that you're pregnant, and there are these tests that you're going to do. A lot of myths live in and around HIV infection. People thinking once you're HIV positive, your child will be HIV positive, and many other things like that. Is there truth to this myth?
No, that is a myth, like you're saying. HIV, it's something that can be prevented from being transmitted to the baby before they are born. Because we give the mothers treatment on the day they come for booking. Once they will discover that they are HIV positive, we initiate them on treatment. And we educate them on safe sex with the partner. If the partner is not there, hence I say it's important for the partner to be involved in this pregnancy most of the time. So we give the mother the treatment, we explain the disadvantages of not taking the treatment correctly, because that might affect the viral load, as I've said before. That if it's high, chances of transmitting it to the baby are very, very high. So we encourage mothers to know their status, give prophylaxis. It helps, because most of the babies with the mothers who took their treatment whilst they are pregnant, their outcomes are very good, because we test the babies at birth. And the baby's PCR, if it's negative, we are more than happy that we have done our jobs as the midwives and the sisters at the clinic, because that is the goal. We need to eliminate any HIV transmission from mother to child at a very, very early stages of the mother's pregnancy.
Lovely to hear. So we're going to continue the discussion. We've got Nomakala from Mpumalanga. Nomakala, good day. Hello, Nomakala. Okay, it seems Nomakala is no longer there. Let's continue this discussion around prevention of mother-to-child transmission. A big, big program that is, pushed out at a clinic level to get mothers to start their antiretroviral treatment so that infection isn't passed down from the mother to the child. But what happens after that? So this child is now born. You've done the PCR, which is a blood test to check if the child is HIV positive or not. If the child is HIV negative, what are the steps that follow then onwards? Because there's discussion around breastfeeding. Can the mother breastfeed? So can an HIV positive mother breastfeed their HIV negative child?
Yes. The mothers can breastfeed their children as long as they've been monitored through the pregnancy and we are sure that the viral load is suppressed.
Okay.
Because the important thing is suppressing this viral load. So it is safe to breastfeed your child. Also, in the labor wards, they normally give the child a prophylaxis treatment, which we give at birth. And it depends if the mother booked a bit late, the prophylaxis would go up to 12 weeks. But normally we give it up to 6 weeks. So it is very, very important for the mothers to take their ARVs so that even the babies can be breastfed. We are not discriminating against them. Because the mother can breastfeed up to a child is 2 years. There's no limit in that.
The important thing is that viral load that is suppressed, so the mothers need to continue to take their treatment.
Yes.
I think Nomakala is back. Nomakala, what's your question? Good morning.
Hello, kunjani?
Ngiyaphila njani ma?
Siyaphila. Ngicela ukubuza mina ngoba ngi-pregnant and ngimdala ngina 53 years.
Wena 53?
Yeah, HIV positive. Ngina 4 months pregnant manje.
Okay.
So akusiyi risk na of kanjani angazi.
All right, so we've got a situation here where Nomakala says she's 53 years old, currently 4 months pregnant, and we're talking about risk stratification. So is this a patient that you would treat at a clinic, or is this a patient that needs to be transferred to a bigger facility such as a hospital to be seen by the specialist?
Okay. Hello, Nomakala. Nomakala is old, obviously. I'm happy that she's at least below 20 weeks of gestation. So Nomakala would need to urgently need antenatal care so that they can check for any other things that might be a problem as she has got, we call them advanced maternal age.
Yes.
Her age is advanced to be pregnant. So Nomakala would have to come to the clinic so that we can check and do sonars, refer to the hospital for her, so that she is being checked for any genital
issues and any problems.
Or maybe the child might be not of a good status. Yeah, so Nomakala, you need to attend the clinic. And also, I would want to know, Nomakala, HIV positive, does she attend any antenatal clinic now? Or has she been taking treatment before? So those are the
very
things
important
that we
things
need
to
to
look
know.
at. Well, so Nomakala, I hope you heard what the matron has said with respect to addressing this issue. Because of the advanced maternal age, because of other issues as well that may have come about, the HIV infection, you would need to go to a facility. So importantly, book at your antenatal clinic, but they need to refer you to the specialist so that you can be followed up there. We continue this discussion after the ad break. Welcome back to Vital Signs. Namhlanje sikhuluma nge-HIV, ukubreastfeeda nayo i-pregnancy, nokuthi kubaluleke kangakanani ukuthi nonke mangabe-ke nibona ukuthi sengathi nimise i-period yenu noma ucabanga ukuthi-ke upregnant uye eclinic uyothola i-booking. Now, in July 2017, the South African Department of Health again changed their guidelines to align with the World Health Organization's guidelines, which recommend exclusive breastfeeding for 6 months with continued breastfeeding for up to 24 months for women living with HIV on antiretroviral treatment. Now, we continue our discussion with Matron Prudence Mapeka, who is a facility manager at Discovery's Community Health Center, as well as Zandile Kubeka, who is assistant director in the Directorate of Child, Youth and School Health at the National Department of Health. Thank you so much once again for joining us, Zandile. Let's continue our discussion. I think before the ad break, we're looking at this idea of PMTCT, which is the prevention of the mother-to-child transmission. But an important thing that a lot of people don't know about, and I guess, we've termed it myth, we've termed it stigma, is this idea that once you are pregnant, and you are HIV positive and you deliver a child, your child will be HIV positive, which I'm sure the National Department of Health is something that they want to get out there as misinformation. Why is it important to identify women that are HIV positive and start them on treatment as early as we can?
I think this is very important, Doc, in the context of trying to prevent mother-to-child transmission, including during the breastfeeding period or throughout that period of breastfeeding. So if you know your status, you're put on treatment, we know that we can take all the necessary precautions for you to be able to have that prevention of mother-to-child transmission of HIV to your baby. So breastfeeding recommendations, it's along with those lines that we want mothers out there to know that, being HIV positive nowadays, we want to deal away with the stigma around it. Previously women who were breastfeeding exclusively, they will be sort of labeled to say, maybe there's HIV around it. So the fact that the recommendations for HIV positive mothers and negative mothers are the same, it actually it's a way to try and deal away with that stigma, to say every mother, they breastfeed exclusively for the first 6 months and then going forward up to 2 years and beyond. And in that way, there is no categorization to say perhaps you are breastfeeding exclusively because you have HIV.
Yes.
So we think it's a good way of trying to deal away with the stigma, to have general recommendations in line, of course, with the WHO recommendations.
Very important that these recommendations aren't done to make people feel good, but they're done because there's scientific basis to it. So we've got a caller, anonymous from Potchefstroom. What would you like to say to us this morning?
Dumelang bontate na bomme.
Le kae papa?
Ke pedi.
Re teng, re mametse papa.
Potsa ke re no ke na le kgarebe ya ka. Motsadi wa ka.
Eya papa.
It's about 45 years.
Okay.
A thu bana le ngwana, but o HIV positive, o nka di medication tsae.
Eya papa.
Now re ba tla re be na le ngwana, what if into re for re dire.
Okay. Ko ba botsa papa, wena HIV status sa hawa se?
Yeah, ke negative nna.
Sorry papa, a kutlwa?
Ke negative.
O negative. Okay. All right, papa, re ta answera potso ya hona jwalo, utlwa papa. Thank you. So this question I'm sure is one that is always out there, but a lot of people don't know about. The idea that you have one partner that is HIV negative and a partner that is HIV positive, and there's this one need to continue to have a healthy relationship so that sexual interaction can happen between the partners, but importantly in this case, where they'd like to have a child. So that discussion about what then will happen if one person is negative and one person is positive. So, Matron, let's ask you, is it possible to remain negative for the one partner whilst continuing to have sexual interaction with a partner who's HIV positive?
Yes. As long as the viral load is suppressed, and we've got also drugs that we call PrEP.
Okay.
Yeah, just to prevent HIV from getting into another partner. And if also it's an advantage for the partner, the male partner, to have had circumcision with that, it also lowers the risk of transmission. So if the anonymous, yes, is also having those medication which we call PrEP, which also prevents the negative partner from getting HIV, and the partner of a female is virally suppressed, it's safe for them to have a baby.
So I hope that anonymous will clearly handle ke taba ya hore tshwantse wena motho a leng HIV negative o ye clinicing le partner ya hao ba le gona bua le lona hantle ba le qhazetse taba e kaofela ya hore wena o nka dula o ntso le negative jwalo if o qala treatment e bitswang PrEP tshwantse o tsamaya lo circumcise hore decrease infection ya teng le partner ya hao ha ebe yona e positive na tshwantse le yona he yetso sure inka medication ya teng viral load e low le hapo hore he re tsebo hore if o undetectable ha o kgone transmitter HIV and le ka continue le bena le ngwana as you would like. Happy everyone?
Yes.
Good. So let's continue our discussion around this idea of breastfeeding. So we've had a topic like this before where breastfeeding is important. It's something that we'll always highlight. But the idea of exclusive breastfeeding is always highlighted as a difficult thing to do, especially in our setting in South Africa. So what creates this impression that exclusive breastfeeding is a problem?
I think this is one conversation that we must always have. The support around breastfeeding. You know, mothers are going through different stages. There are mothers who are having babies for the first time. There are mothers who are having a second baby. So the support that is given within our healthcare facilities in terms of throughout pregnancy, because you start then, you don't start when the baby is just born today. Throughout pregnancy, you prepare the mother in terms of letting them be aware about the benefits of breastfeeding and throughout the pregnancy. And going forward, once the baby is delivered, if the mother is not supported within our maternity units to initiate breastfeeding within at least an hour, you'll find that mother struggling going forward to get the breastfeeding going. So I think for us to make breastfeeding work and to make mothers believe in breastfeeding, there's a need for a lot of support within our health facilities, even post-delivery, because mothers will come back for those postnatal care visits. You need to check on the breastfeeding. That is where within the period of 3 to 6 days, where most mothers will start experiencing a breastfeeding challenges. It's either maybe their breast will be too full, it's either they might have infections such as mastitis. So in that case, if they receive the support they need throughout those postnatal care visits, they tend to be more comfortable with breastfeeding. If they have someone who will even show them the skills and technique for breastfeeding, you'll find that they are more comfortable to be able to do it better. So it all lies in the support. And beyond the health system, you also need that support from family, from the society being more accepting of breastfeeding, from the grannies at home to encourage them to continue with the practice of breastfeeding, opposed to them saying perhaps you can introduce water, you can introduce other things. So that is one way we can get the exclusive breastfeeding going right in South Africa.
So we've got Zandi from Mpumalanga on the line who's got a question. Good day, Zandi. What is your question? Siyaphila manager.
Khona bengisacela ukubuza ngi-HIV positive since 2005.
Okay.
Then ngibe manje nginomntwana isana elina 1 month.
Okay.
Then umntwana ngathi manje ngimdeliver wathola ukuthi ngiba nezilonda emzimbeni wami ziyaluma and nasemabeleni zikhona vele ziningi ziphuma idoti. Then ngaba nomntwana wathola ukuthi anginayo isupport ukuthi ngathwala amabisi nalo ngihambe nawo esibhedlela bangifika esibhedlela bangiqeda ukumthola ngabreastfeeda umntwana Ngimpresside for 3 weeks. But ngizwa amabele wami abuhlungu and ngwabona ukuthi vele ilonda zakhona zibhede ngababuza esibhedlele kuzoba safe na ukuthi ngimunyise ingane na ngoba ngiphume ilonda emabeleni ngiworried ukuthi umntwana it may happen ukuthi angabi safe.
Yebo ma.
Bese ngamunyisa mangifika la ngimunyisa ibele la cracker. Ngiphule ibele ya cracker. Ngathola ukuthi umntwana kudala amunya igazi lana emabeleni wami. So ngaba worried ngafonela there and then ngibabuza ukuthi ngabe umntwana wami uzoba safe or njani. Bathi ngimele ngifune usizo and then ngathi ukuthi ngiyekise lebele immediately. Sengibonile ukuthi kwenzakalani ngamnika ibisi. Then manje umntwana unikela i-citranavirapine. Then umntwana uphume ilonda emzimbeni. I'm worried ukuthi ingabe umntwanami for now usafe or njani angazi ngoba nama results wakhe azange ngiwathole ngiwathole 6 weeks.
Mawuyovakasha futhi. Okay, no problem. So answer umbuzo wakho, okay? All right. So that idea, exactly what you've spoken about, right? Why it's so important to support breastfeeding mothers. So in her situation, what needs to happen, Matron?
Okay. Zandi, like she said, she had attended to a clinic to report that. Normally, when the baby is exposed like that, we also repeat the test at PCR test at 10 weeks.
Okay.
So that we see how best the child is being prevented from getting HIV. But now she's also started the child on formula feeding, which is not a bad sign because we don't know what is wrong with her condition of the breasts. So it is okay for her to give that to the child. And also the child is on a prophylaxis treatment. I don't think she should be worried that much. Hence she says they gave her nevirapine at the clinic. What we will be worried is what is coming out of the breast and why is the baby developing the sores and all that. The child needs to be monitored closely as well. So I would advise her, she can continue with the formula that she's giving the child until she's
better and has been supported, has been looked at, and has been examined to check that she doesn't have the mastitis, that she doesn't have any of those issues. But then let's discuss this. So someone that has an issue like mastitis or sores on the body or the nipples are cracking and there's blood, they obviously then have issues or are unable to breastfeed at that point in time. We will then suggest then, because the child still needs to eat, for them to formula feed. Can we hop back once or after Zandile or any other woman that had these issues, go back to exclusive breastfeeding?
This is a very important discussion, and it comes out a lot in terms of, what does then a mother do once she has now introduced a formula? Is it possible for her to go back? There's a lot of anxiety around whether then the baby will get the infection or not. So the most important is to acknowledge the fact that if the mother is taking the ARVs very well, she's adhering to the treatment, and the viral load is actually very minimal, the chances of transmission are very low. However, when it comes to issues of mothers having introduced formula, it's best for us to look at it holistically to say how old is that child at that point. And being a 1 month, I think she did say 1 month old.
Yes.
I think it will be very critical for her to be able to revert back to breastfeeding. So in the past, we know that there were issues around saying if a mother has already introduced formula, that's the way to go. She can continue in that direction. There's no means or way to go back to breastfeeding. So that is the discussion around mixed feeding, to say, what then do you do if you have mixed fed already? So it is possible to still relactate, and critical with mothers who are having infections such as mastitis, or they've got a londa or on the breast. It's good if, in case one breast is affected, the mother is able to maybe breastfeed from the other breast, or if both breasts are affected, she is able to actually express to keep the milk flowing. Because the other risk of having introduced formula and then you stop on the breastfeeding, you'll find that your milk supply become affected. So we know that the practice of mixed feeding actually interferes with breastfeeding. So it will be good for the mother to continue expressing her breast milk, and she can be able to revert back to breastfeeding. We know that she's already on antiretrovirals. We know that the child is also on prophylaxis. So the risk, because she has already mixed fed, will almost be not there because she's on the antiretroviral
Especially if she
treatment.
continues to continue on one of the parts that are supplied, you know, whether you're going formula or you're going breast, it's important. I hope uzwe kahle ke sisizana ngokuthi ke ungayenzani as soon as amabele elungile angasengana ama infections sekungena izilonda rather ezikhulayo emabeleni ungakhona ke ubuyele ke breastfeeding ngane, but ngaleso sikhathi uloku continue loku expressa ibisi. Another caller on the line, anonymous from the Northwest. Good day.
Hello, njani?
Yaphila njani sis?
Ngikhona. Nginombuzo lana. I'm HIV positive, ne?
Okay.
Yes. Ngathi mase ngideliver ingane, bangibuza ukuthi ngizobreastfeeder or ngizomnika ibhodlela. So ngabatshela ngathi ngifuna uzenza zoyi-2 because ngizoya emsebenzini, mangisemsebenzini asale eyanye ibhodlela and mangibuya emsebenzini ngimbreastfeed. So bangitshela ukuthi no, kufanele ngenze i-1 because ngizofaka umntana kwi-risk. Angatholi HIV, so mangichoose i-1 is either ngiyabreastfeeder or ngichoose ibhodlela ngeze ngikwazi uzenza ziyi-2. So ngabatshela ukuthi okay ngizochoose ukubreastfeeder, bathi mara umntana uzoba seriskini.
Yes.
Because mangemsebenzini uzokwenza kanjani. Okay, ngabatshela ukuthi okay sharp ngizochoose ibhodlela ke angazi ukuthi ibinto elungile abasi-advise kahle basitshela nje ukuthi yenza kanje wenza kanje. So ngachoose ukuthi okay ngizonikeza ibhodlela umntana mangizange ngambreastfeeder ngamnika ibhodlela base banginika iphilisi la khona angilazeli ukuthini bangitshela ukuthi no lizovala ukuthi amabele angaphumi ibisi, that's all.
Okay, sizokuchazela ke namhlanje sokuexplainela ukuthi mayisephela le show wazi kahle ukuthi bekufaneka wenzeni nokuthi wenzani. Yezwa sis.
Okay, ngiyabonga.
All right, so that big issue, right? This idea of mixed feeding. You know, as healthcare professionals, yes, we're very high within our beliefs. We say things to people and we walk away and believe that they understood what we're talking about. But a lot of people do have jobs. So you can deliver your child. Your employer might not necessarily give you 6 months off. And you may need to go back and make some money for your child. But this idea of breastfeeding is not something that you're able to do. So a lot of people then have this idea of mixed feeding, where when I'm home, I'll breastfeed. And when I'm at work, my child will have formula. Is this something that we generally should advise? Or should we be doing what she's suggesting, that the nurses or the people that saw her at the facility were, which is you must pick one or the other?
Okay, I can answer that. First of all, if a mother is a working mother, we don't stop breastfeeding. We would rather say the mother should express. We do have what you call express milk, that she can educate whoever that is a child giver that will be staying with a child at home to continue feeding this child. But what we discourage with the exclusive breast milk, it's them giving it through a bottle.
Okay.
We'd rather say cup feed the baby.
Okay.
So that the baby doesn't get confused with the nipple. Because the rubber nipple, the rubber, what's this? The teats.
Yes.
Yeah, plus the nipple. If the baby gets used to the rubber teats, they normally don't want the breast
Shy away
anymore.
from the breast.
Shy
Okay.
away. So we normally encourage the working mothers to express and keep the milk for the child, so that whoever that is taking care of the child can continue. And with the companies, there is a breastfeeding policy that needs to be implemented in the company, where women who have just had a child must be given an hour to express, which we'll call breastfeeding in a way. Must express because the breast will be full during the day. That milk, she can keep it in the fridge for days to use, as long as the child is on the breast milk. So that was, according to me, they were supposed to tell her to do that in the first place.
So because Anonymous, your case is different in the sense that at this point you were given medication to stop the milk or stop your breast from lactating themselves, and your child's already on formula at this point in time, there's very little that can be done now. But for all the mothers in the future, when this situation is brought in front of you, you have your options. You can continue to exclusively breastfeed, even though you'll be back at your job because you can express. But if you choose to use the formula feeding, that's also an option that you can have. But breastfeeding is always promoted much higher than formula feeding is. Well, thank you so much, Matron Prudence, for joining us today to highlight the importance of why ANC visits are so important and why you should book as early as you possibly can, so we can identify these issues and, of course, start getting you and giving you a healthy pregnancy. Thank you for joining us. We'll continue our discussion, of course, with the National Department of Health after this ad break. Welcome back to Vital Signs. Now, breast milk plays a vital role in reducing child mortality. It has all the nutrients that a baby needs in the first 6 months of their life, and of course has health benefits that extend into adulthood. This is why organizations such as UNICEF and the World Health Organization recommend exclusive breastfeeding, not other food, not other drink, not even water for infants in this period of their lives. Now, globally, numerous policies and programs have been put in place to promote and support breastfeeding, and South Africa has also been promoting exclusive breastfeeding for the time. But the country has also got one of the lowest rates of exclusive breastfeeding in Africa as well as globally. We continue our discussion with Zandile Kubeka, who is the Assistant Director in the Directorate of Child, Youth and School Health at the National Department of Health. So breastfeeding is this discussion that we're having today. And of course, HIV plays a very important role. I think with the number of callers that we've had come in, and of course, just the stats that we have in South Africa, it's very clear that this is a discussion that needs to be had. So back to this idea of why is it important that HIV-positive mothers breastfeed? Why is that important?
I think this is a very critical question, even in the context in general and also in the context of HIV. What I can say to highlight a few areas that maybe we can pay more attention and raise awareness for mothers out there is the fact that, actually, if you breastfeed, even in the context of HIV, you are increasing the chances of your child for survival. You are also increasing the chances for your child to be able to grow optimally and develop optimally. So those are some of the key benefits. You will know that, when you look at breast milk in terms of composition or what things are there in breast milk, it's got so many things in there in terms of growth factors, immune factors. You're talking about the antibodies, we're talking about the white cells, we're talking about vitamin A. All those things are very important in terms of reducing the severity of infections. So that is very important in the context of HIV. So we do know that children who live with HIV, if they happen to have what we call intercurrent illnesses, like your common childhood illnesses as well, such as diarrhea and pneumonia, we know that breastfeeding has an important role to reduce the incidences of diarrhea and respiratory tract infections. So also in the context of HIV, you know that the growth factors in breast milk, the protein in breast milk will be easy to digest. You know that the fats in breast milk contains what we call essential fatty acids. That is very important for optimal development of the brain of the child. There's also iron in breast milk that plays a very important role in terms of growth. It is in small quantities, but it is easy to absorb. So when you look at all these benefits of breastfeeding, you will know, as you've said earlier, that for the first 6 months, it's a complete source of nutrition for the child. No need to give any other thing. The child can grow optimally on breast milk alone. But beyond 6 months, there's also additional benefits in terms of what breastfeeding could contribute to the overall nutrition of the baby. So up to more than half of the nutritional needs of the child can come from breast milk from 6 to 12 months. And then going from 12 to 24 months, up to 1/3 of the overall nutritional requirements of the child can come from breast milk. So hence we say it contributes to reducing all forms of malnutrition. We know malnutrition contributes globally to about 60% of child-related deaths of about 10.9 million children across the world. So we know that, the 2/3 of those numbers, it is because of not breastfeeding optimally, or it's because of not breastfeeding at all. So it's important that we promote breastfeeding, even in the context of HIV, for growth, for reducing severity of infections as well.
So in about 30 seconds, we've really run out of time. The idea of socioeconomic factors and how that affects feeding a child. Why is it important to address these?
Well, it's very important, and when you look at feeding in general, that period from 6 to all the way 24 months. For us, when we say breastfeeding is a source of nutrition, it's very important because it contributes to that dealing with the socio-economic factors where mothers, they don't know how to, where they will fend for the next meal for their children. So if we incorporate breastfeeding in that complementary feeding phase, we know that it will already address half of the nutritional needs of the baby. So from our perspective, we think mothers are still able to provide that optimal diet for their children, incorporating breastfeeding as well throughout from 6 months up to 2 years and beyond as part of the nutrition of the child. So we think that is one way to deal with the socio-economic issues surrounding feeding of infants. We know breastfeeding will contribute to reducing poverty, food insecurity, and hunger.
Well, look, I think you've addressed and we've looked at this substantially today, and it's so important to have discussions like this. Thank you so much for joining us today and hearing what the nation, what the Department of Health really feels and thinks about these things, the policies they've put into place, and of course, getting moms out there to do what they think is important, which is breast is best. Thank you so much to all the guests that joined us today, and thank you for your questions and all your participation in our show, Vital Signs. I'm Dr. Musa Mtomeni. Take care.